Hello, good evening, and thank you very much for staying with us for this late session. And I congratulate Professor Dr. Rag for his elegant presentation. And unfortunately, I have to contradict what he said. This actually debate is not about the is it useful to treat the accessory, the anterior accessory great branch tributary of the great saphenous vein or not. It's about how do you treat it. So I would recommend continue as a hero, say no for zero. So remember the Hippocratic Oath, first do not harm. And the history actually of resecting of great saphenous vein, I don't want to go through the history because of sake of time, but it was the first idea to remove part or a segment of the vein to treat varicose veins. And this is not a new idea. And there is something actually mentioned in the old papyrus papers and in the Arabic old medical scholars that actually they were removing the varicose veins in the past. In 1916, Homans in Boston started the radical operation for severe varicose vein with venous ulcer, including crossectomy, stripping of the great saphenous and ulcer excision. And since then, the recurrence remained an unsolved issue. And I will go with what Professor Dr. Frolini mentioned, that actually the term recurrence, when we are talking about varicose vein, might be a wrong term to use because it is a chronic disease like diabetes and hypertension. And if something started to be clinically evident, this doesn't mean that the disease disappeared for a period of time and then it appeared again. Actually, the disease is still there, whatever we are doing for the patient. So in 1987, Glass introduced the new vascularization as the main cause of recurrence. Endovenous laser therapy was firstly introduced in 1998 by Spanish phlebotomist Carlos Bon. There are conflict of claims, and different authors claim that they have used other techniques for thermal ablation of the varicose veins. And the technique, as actually advised by all the companies, mentioned that replace dilator with catheter and advance to the saphenofemoral junction, replace the guide wire with the laser fiber using the ultrasound in longitudinal view, advance the laser tip until 2 centimeters distal to the saphenofemoral junction, ensure that the IEV is visualized. So this is their own recommendation. All laser companies recommended that. Start thermal ablation 2 centimeters distal to the saphenofemoral junction, regardless to type of fibers and laser wavelength. We know that actually there are a lot of advances that happened in laser production and manufacturing as regard laser length and type of fibers, and they didn't change this IFU. For varicosities in great saphenous vein or short saphenous vein, endovenous techniques have largely replaced traditional surgical stripping and vein ligation. And this is because of the complication of surgical stripping, which includes extensive ecchymosis, scarring, hematoma, lymphocyte infection, nerve injury, and DVT. While actually recent research had showed that DVT is not really different from surgery to radiofrequency, for example. Initially, bare tip laser fibers emitting laser light with relatively low wavelength from 810 to 1000 were used. And recently, we have higher laser wavelength, 13 to 1900s. And the fiber tip has different configuration to minimize the postoperative inflammatory pain, bruising, and endothermal heat-induced thrombosis. And these are the different tips of the laser that are used nowadays. But as regards recurrence, surgical stripping was associated with high recurrence, up to 50% in patients in 5 years, most often as a result of incomplete phlebectomy, persistent venous reflux, or new vascularization. But since the recurrence was an issue, and since the introduction of the laser, there were hundreds. I will not go through all these studies, and some of them are randomized controlled trials, many of them were meta-analysis. And all these studies in different, and even in the old era of the laser, they studied laser versus surgical intervention versus stripping and high ligation. And actually, most of these studies included patients who were treated in the IFU, which is 2 centimeters away from the saphenofemoral junction. And still, the results were very satisfactory in favor of laser in comparison to the surgical stripping and high ligation. So compared with high ligation stripping, most studies reported no statistically significant difference in varicose vein recurrence. And we have to remember this very important. It's totally different thing when we are commenting on recurrence as a clinical scenario in comparison to radiological finding. And this actually was very obvious when we talked about a recurrence in following laser and radiofrequency, that most of these recurrences were not really clinically relevant, and actually the quality of life of patient when they assessed were superior in comparison to surgery. So not every recurrence or a long stump will be clinically relevant and will upset the patient. So according to two systematic reviews and meta-analyses, recanalization was the most common cause of recurrence after EVLA, whereas new vascularization was more frequent in the high ligation and stripping. And we know from the past, actually, that crossectomy didn't improve the outcome of endovenous laser. I mean the surgical crossectomy. The recurrence in the surgical group, as you can see, is followed actually by new vascularization inside the fibrous tissue. And you can see this is the image of the small trabecular vein after the high ligation. And after a few years, this what will develop. And this is totally different in the thermal ablation era. But if you go to the European Society guidelines, you'll find actually the recurrence actually is not a one factor problem. Again, I emphasize that actually the term recurrence shouldn't be used, but this is what we are used to say about radiological or clinical appearance of the varicose vein post-procedure. But taking in consideration all these causes, it's very difficult for me to ignore all these causes and just try to target one thing against the instruction for use of the company, which is the accessory anterior tributary of the great saphenous. So there are many articles talked about the fate of tributaries after the thermal ablation. And the saphenofemoral junction tributaries are usually left untreated at the time of endovenous ablation of axial vein. And literature search and analysis of evidence reveal that the junctional tributaries are one of the commonest, ranges between 8 to 31% cause of recurrence following endovenous ablation of the axial veins. So should we treat them? Recurrence of varicose veins after endovenous ablation of the great saphenous in randomized trial, and again recanalization was the most common cause of recurrence, about 32%, followed by the development of anterior accessory saphenous vein. So actually recanalization was actually double the possibility of recurrence due to anterior accessory saphenous vein incompetence, and incompetent calf perforating veins were an infrequent cause, 7%. So should we ablate the anterior accessory origin? Pushing the boundaries, there were many publications about flush closure of the saphenofemoral junction with laser. And the conclusion that actually they have mentioned is flush closure and short stump gave better early results than the formerly recommended technique, which is 2 centimeters away from the saphenofemoral junction. There is not a higher risk of complication. They're talking about the endovenous thermal thrombosis if the junction is occluded flush with the femoral vein. But ultrasound findings in 33 limbs, if we go for analysis of these studies, 39.7 flush closure of the saphenofemoral junction was achieved without any patent tributaries, but they couldn't achieve this in 13.2 patients because the tributaries, as we know from the surgery when we are doing surgeries, not always the tributaries are coming directly from the great saphenous. Sometimes they're coming from the conflict between the great saphenous and the femoral vein, and sometimes actually we see them coming from the main common femoral vein. They're not coming from the great saphenous. So theoretically and technically, we cannot guarantee that even if we go flush to the saphenofemoral junction, that will ablate all the tributaries. And the other thing, only radiological recurrence was assessed. Clinical recurrence was not. Quality of life was not. So this is another study about feasibility and safety of flush endovenous laser ablation. All these studies actually go with my colleague, Dr. Rag, that actually it's better. No local growing complication occurred and endovenous heat-induced thrombosis occurred in 2 patients only, which is 1.6%, which is very similar to most of the previous studies comparing laser and surgery DVT occurrence. But again, I couldn't perform the study mentioned that they couldn't perform the flush occlusion in 6% of the patients, and flush occlusion was observed in 94.5 at 1 day, and this dropped to about 82 in only 6 weeks. So a lot of other publications and commentary from eminent venous surgeons and interventionists. I will not go through all of them, but they mentioned there was a statistically significant difference noted according to the greatest diameter of the stump. If it's 0.41 centimeter in group 1, which is the laser crossectomy, and 0.6 centimeter in group 2, which is 2 centimeter away from saphenofemoral junction. And they have mentioned that the reflux in the anterior accessory saphenous vein was observed in 8% in group 1 and 14% in group 2, which was statistically significant. And reflux in the stump was detected 4% in group 1 and 19% in group 2. But again, this was radiological recurrence and reflux. There were no statistically significant difference in the venous clinical severity score and SEEP classification improvement between the two groups at any time point of follow-up. And this is the main paper conclusion. There were no between group differences according to satisfaction with treatment at any time point. So we know from the recent history that actually pushing the boundaries and going outside IFUs always carry a worse prognosis, and we have to remember not to do any harm. So IFUs, these are set by the body who worked hard to invent, study, explore, and record everything related to their own products. Then all of this detailed process was approved by health authorities. So if anyone want to adopt this new technique, I have no problem. I have no problem to try to add a foam sclerotherapy treatment for the anterior accessory saphenous vein. But it's better to talk to the companies, change the IFU, and then everyone will be happy. And we will treat all the patients flush to the saphenofemoral junction. Thank you very much.